Welcome back to our Clinical Explainer series. Today, we're getting right to it, breaking down the specific nitty-gritty exercise protocols for bilateral vestibulopathy. This explainer is based on the literature review, Bilateral Vestibulopathy, Rehabilitation Strategies, Substitution, Adaptation, and Quality of Life Outcomes, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com. So, let's kick things off with a question I know every single one of us faces in the clinic. How long should a bilateral vestibulopathy home program actually be? Well, the magic number is about 30 minutes daily. But, and this is a massive but, it has to be the exact right 30 minutes. It needs to be cleverly anchored to your patient's day, and it absolutely has to be managed within a vastly tighter symptom-provocation window than you'd ever use for your unilateral cases. Here's our clinical roadmap for today. We're covering 1. The substitution paradigm, 2. The program template, 3. Progression rules, 4. The symptom-provocation window, and 5. Long-term compensation. All right, let's jump right into Section 1, the substitution paradigm, and exactly why standard adaptation completely fails these patients. Listen, treating these cases demands a fundamental paradigm shift from us. You know how standard vestibular rehabilitation therapy relies on a peripheral vestibular signal being present to drive adaptive plasticity? Well, in bilateral vestibulopathy, both labyrinths are deficient. It's like trying to tune a radio that isn't plugged in. Classical gaze stabilization exercises like VOR ×1 and ×2 just don't work here because there simply isn't enough peripheral signal left to adapt. So instead of adaptation, our entire game plan has to pivot to substitution. We're literally teaching the brain to rely on vision, proprioception, and cervical reflexes to fill in for that missing vestibular input. This substitution strategy is built on 4 main pillars. First up, cervico-ocular reflex enhancement. Since the vestibular signal is gone, those cervical proprioceptors really have to step up to the plate. We train this using slow-frequency head movements. We're talking 0.25 to 0.5 hertz, while the patient maintains visual fixation. Next, we've got saccadic substitution. This is where we teach patients to preemptively leap their eyes to a target before they even move their head, instead of trying to track smoothly. Then there's visual pre-programming, which ties right into that. Fixate first, then move. And finally, proprioceptive training in darkness. When you take vision out of the equation, the feet, ankles, and trunk become the absolute sole source of balance control. This is exactly where your foam stances and tandem walking really shine.
Moving on to Section 2, the program template. Let's design that 30-minute daily routine.
Okay, so how do we actually dose this? Here is your evidence-based daily prescription. And I want you to notice right away how heavily this prioritizes balance work over gaze stabilization. Cervical ocular exercises, those should be done 3 to 5 times daily, but for just 1 minute per axis. Saccadic substitution is twice daily, 10 reps in each direction. But take a look at those bottom 2 rows. Proprioceptive balance work demands 10 to 15 minutes every single day, and dark or dim training needs another 5 to 10 minutes on top of that. All in, that brings your total home program to roughly 30 minutes. It's heavily weighted toward postural control and substitution, simply because that's what's going to keep these patients from falling. Now, the real challenge is getting the patient to actually do the work, right? 30 minutes is a huge daily ask for a patient who's already exhausted just trying to stay upright. But here's the thing. The literature is super clear that securing just one functional win at session 1 literally triples adherence. You've got to anchor this routine to the patient's daily life using behavioral cueing. Have them practice saccadic substitution right before they read the morning paper. Get them to do their proprioceptive foam stance while brushing their teeth. Tying these exercises to habits they already have is, hands down, the best way to guarantee they'll actually stick with it. Okay, let's head into Section 3, progression rules, and talk about how we safely step up the challenge. When we're tackling static balance, we absolutely cannot overwhelm the patient's already diminished system. We need a very strict linear progression here. Step 1 is always reducing the base of support, moving from a normal stance to feet together or into a tandem stance. Only once they've totally mastered that do we move to Step 2, which is closing the eyes. This completely strips away that visual substitution layer, forcing them to rely purely on proprioception. And only after they conquer that do we hit Step 3, adding a compliant surface, like a foam pad. If you jump straight to foam with eyes closed on day 1, you aren't training them. You're quite literally just teaching them how to fall over. For dynamic gait training, the progression is just as conservative. Step 1 is adding head turns while walking. Step 2 brings in a dual-task cognitive load, something like having them count backward by 3s while they walk down the hall. Then Step 3 introduces uneven terrain.
And I can't stress this enough. An incredibly vital tool here is light touch. Letting the patient use just a light fingertip touch on a wall gives them essential cutaneous proprioceptive feedback. It allows for safe, early loading, way before they're actually ready for independent dynamic gait. That brings us right to Section 4, the symptom-provocation window. This might honestly be the single most critical safety concept in this entire explainer. So in traditional unilateral vestibular rehab, we're pretty used to telling patients to push into their dizziness, right? We often accept elevated symptoms for 20, maybe 30 minutes post-exercise. You absolutely cannot do that here. The symptom provocation window in bilateral vestibulopathy is incredibly tight. Your target zone is just mild instability that settles within minutes. That's it. If they're feeling wiped out for hours, the dose is simply too high. And here is a warning every single one of us needs to internalize. Severe instability that does not settle is dose failure, not progress. Pushing a bilateral patient too hard just exhausts whatever limited compensatory resources they have left, and it drastically spikes their fall risk for the rest of the day. Remember, less is more here. Hit the specific substitution targets, create a very mild challenge, and then back off to let the nervous system recover. Finally, let's unpack Section 5, long-term compensation, and look at what this protocol actually achieves physiologically. The whole point of sticking to that 30-minute protocol becomes crystal clear when you look at this sensory reweighting model. See how that vestibular block in the middle is drastically reduced? To keep the patient upright, the brain literally has to enlarge the visual and somatosensory roles. And sitting right on top of that entire system is cognitive compensation. We're talking attention, anticipation, and motor planning. So when you prescribe those daily proprioceptive exercises in dim lighting, you aren't just giving them busy work. You are actively driving the expansion of that somatosensory block. I want to leave you with one final clinical pearl about gaze stabilization. We've established that VOR times 1 viewing is basically wasted time for pure bilateral loss cases, right? If there's zero vestibular function, pure substitution is your only path forward. However, if you've got a patient with severe but incomplete bilateral vestibulopathy, meaning they still have just a tiny sliver of residual function left, you can actually sprinkle in a limited amount of classic VOR times 1 viewing on top of their substitution program. Just be incredibly selective about who gets it, because you really don't want to waste their very limited daily energy. In Part 4 of this explainer series, we close with long-term compensation, quality of life outcomes, maintenance, and the onward referral pathways. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. But before you see your very next patient, I want you to ask yourself, are you accidentally training them to adapt a signal that no longer exists? Or are you truly teaching them how to substitute?